We're going to continue in Chapter 57 by discussing inflammatory bowel disease, including ulcerative colitis and Crohn's. I went back to the beginning slide of this presentation because I wanted you to take a look at this graphic. This graphic shows both inflammatory disorders that we're going to discuss here with Crohn's disease on the left and ulcerative colitis on the right. One of the indicative things about Crohn's disease on the left is you're going to see those skip lesions where you can see healthy colon interspersed with inflamed colon. You can see on the right that the ulcerative colitis is usually in the distal portion of the colon. So inflammatory bowel disease affects about 1.4 million people in the U.S. Peak age for diagnosis for these diseases is 30 to 40, and then again from 55 to 65. But you will see that Crohn's is generally caught earlier than that, and ulcerative colitis is usually caught later. Women are affected younger, but men generally get inflammatory bowel diseases more as middle-aged and older adults. Some of the medications that we see for inflammatory bowel diseases, they're generally similar between ulcerative colitis and Crohn's, where we see aminosalicylates, which are used to decrease inflammation. Glucocorticoids, which are also used to decrease inflammation. They're usually prescribed during flare-ups and then tapered off to avoid long-term steroid use, because we have so many complications with long-term steroid use, like hyperglycemia and peptic ulcer disease, as well as increased infection risk with immunosuppression from glucocorticoids. Antidiarrheals might be used, but we have to use caution with these patients because they can cause colon dilation. So that's an education point for these patients, is to not use antidiarrheals unless their provider knows about them. Immunomodulators work with the steroids to decrease inflammation, and they're used more frequently in Crohn's. Don't forget, these immunomodulators as well can cause immunosuppression. Sometimes our patients will need ostomies because of inflammatory bowel disorders. And we also might see these patients getting TPN, total parenteral nutrition, for bowel rest when they're having exacerbations. Ulcerative colitis is widespread inflammation, mainly of the rectum and rectosigmoid colon, but it can extend to the whole colon if someone has extensive disease. In both ulcerative colitis and Crohn's disease, we see periods of remission and exacerbation where a patient might feel well, a state of relative wellness, and then have an exacerbation. The distribution of the disease may remain constant for years, where they're not having an increased part of the colon inflamed. But like I said, it is associated with remissions and exacerbations. So in an exacerbation or a flare-up, we can see more of the colon become inflamed. And then all of a sudden the disease distribution is over more of the colon than it had been previously. There are a lot of different factors that can cause these flare-ups, like an infection, sometimes stress. Generally, patients have blood and mucus in their stool. They report an uncomfortable, urgent urge to defecate, and then have that colicky abdominal pain, and that is generally relieved by defecation. Table 57-4, Complications of Ulcerative Colitis and Crohn's Disease, on page 1174 in your IGGI 8th edition, is a good list of some signs and symptoms, including malaise, anorexia, anemia, dehydration, fever, weight loss. The etiology of ulcerative colitis is really unknown, but as so many of these diseases, it could have multifactorial etiology, including genetic, immunologic, and environmental. But there is good reason to believe that there's a genetic aspect because it's often found in families and twins. If a twin has ulcerative colitis, more than likely the other twin will have it as well. There's also a possible link to autoimmune dysfunction with ulcerative colitis. Diarrhea is going to be one of our complications that, of course, can cause fluid and electrolyte imbalances, dehydration, and hypokalemia, which could cause problems with the cardiac system. Continued complications could be that because our intestinal mucosa becomes inflamed and edematous and reddened, it can have ulcers and abscesses, and this could result in necrosis and increase in severity in the disease. Eventually, this increased edema and the thickening of the mucosa could lead to a narrowed lumen, and this could cause a partial bowel obstruction. Long-term cellular changes are also possible in patients with ulcerative colitis, and this could put people at increased risk for colon cancer. Our assessment of patients with ulcerative colitis should be our general GI assessment that we keep talking about that we can find in Chapter 52. Want to know about food intolerance, what their normal bowel pattern is, and their abnormal bowel pattern, like what happens when they're having a flare-up and what happens when they're in remission. Wondering about pain, exposure to antibiotics, travel, NSAID use, because NSAIDs can cause flare-ups. We want to know about any kind of fever. These folks might have especially like when we're first assessing a patient who has ulcerative colitis, before they have an official diagnosis, people might have really non-specific abdominal symptoms. They might have similar symptoms to a person who has a bacterial or viral illness, and might even be told, for potentially an extended period of time that it'll just go away. Use antidiarrheals, make sure you push fluids before we get a definitive diagnosis of ulcerative colitis, which we would usually do with colonoscopy, MRI, CT, barium enema. A CBC is probably going to show decreased hemoglobin and hematocrit and increased white blood cells because of infection. We also might see a decrease in sodium and potassium if we do a basic metabolic profile, because we might, with the increased diarrhea, we might see those electrolytes be wasted. Our assessment should also include a psychosocial assessment, because these patients are frequently worried about being tied to their toilet because of how many stools they are having in a day. It causes stress and anxiety. Eating might cause pain and cramping, and if you think about our society as a whole, generally a lot of what we do focuses around eating. So patients might not be feeling like being social because they don't want to eat and they don't want to decline food in front of people. If a patient is having a severe exacerbation, bowel rest might be indicated. Another thing that we can do as far as education to prevent flare-ups is we can suggest that patients decrease caffeine and alcohol, as those can increase diarrhea and cramping. We might want to suggest that raw vegetables and foods high in fiber, as well as lactose-containing foods and carbonated beverages, pepper, nuts, corn, dried fruits, and smoking tobacco, all of those things might aggravate ulcerative colitis. Eventually, if we're seeing more exacerbations than remissions and having considerable issues, we might have to have a permanent or a temporary ileostomy. That would be if the entire colon is inflamed. If part of the colon is inflamed, we might see a colonostomy as well. But generally, if we're doing a temporary treatment for ulcerative colitis, we would probably see an ileostomy. This is a picture of ulcerative colitis showing severe mucosal edema and inflammation. You can also see these ulcerations and where the bleeding was. These are some diagrams of ileostomies where the ileum is going to be taken out of the body. We're going to see the stoma formation. And in these restorative proctocolectomies with ileo pouch and anal anastomosis, we're seeing that this is going to be temporary, where the colon is removed and part of the ileum is used to kind of replace the colon. So in the first stage of surgery, the colon is removed and the ileostomy is created. And in the second stage of surgery, after that reservoir, so the colon replacement has had time to heal, we re-anastomose the ileum, and then a patient is allowed to defecate through their anus again, but just without a colon. This figure is 57-2 on page 1178 in Iggy's 8th edition. Another chart that I believe is on that page as well is chart 57-4, Patient and Family Education, Preparing for Self-Management Ileostomy Care. Here's another ileostomy in that right lower quadrant. It's going to be a total proctocolectomy with permanent ileostomy. So in this situation, we just have that colon totally removed, as well as the rectum and anus. This is 57-3 on page 1178. Initially, after surgery, the ileostomy output will be dark green liquid with some blood, but eventually the small intestine is going to start absorbing more and more of the nutrients and fluid from the stool, kind of almost taking up the colon's job. And eventually our stool might even become a little bit more solid out of this area, but of course still not as solid as it would be from the colon. Skin care around those ostomies is going to be a really high priority and huge education. There's not really a special diet that patients with ileostomies have to follow, but many of them intentionally avoid foods that would make them gassy. With the ileostomies, there's no special diet that's needed, but people generally like to avoid gassy foods and high fiber foods. We will refer patients to ostomy support groups. It generally helps them to have someone who kind of knows the ropes, knows some of the concerns that they might have. It's an important thing for them to make contact with somebody who has similar concerns or who has had similar concerns. It really helps with adjustments. Here are some pictures of ostomy skin barriers like wafers and then the appliance pouches. Crohn's disease. Most of the people diagnosed with Crohn's disease are going to be adolescents or young adults. Most people diagnosed with Crohn's disease will be adolescents or young adults. Crohn's is a chronic inflammatory disease of the small intestine, colon, or both. And like we saw in that first figure, it does have those skip lesions where we might have healthy bowel between the inflamed bowel. It can affect the GI tract anywhere from the mouth to the anus, but it's mostly in the terminal ileum. Crohn's is slowly progressive and it's very unpredictable. It's got generally involvement of multiple regions, like I was explaining, those skip lesions with healthy bowel between. Just like ulcerative colitis, Crohn's disease has exacerbations and remissions. Hemorrhage is more common in Crohn's disease than ulcerative colitis, but it still can happen in ulcerative colitis, but it's more common in Crohn's disease. And malabsorption is also more common in Crohn's disease. Fistula formation is something that's unique to Crohn's disease, and it's when there's an abnormal opening between two adjacent organs or structures. Like this could be between the small intestine and the bladder, intestine to intestine, intestine to vagina, or even intestine to the skin. When this happens, this is what often causes Crohn's disease patients to need surgery. This could also cause us to see abnormal labs, like if we did a urine test, we might see white blood cells in the urine because of the fistula from the intestine to the bladder. There is a high risk of systemic infections, skin problems, and malnutrition and fluid and electrolyte imbalances because of these fistulas. A patient with Crohn's disease might present with unintentional weight loss, manifestations of malnutrition, and fluid and electrolyte imbalance. We might see decrease in vital nutrients like vitamin B12. Often these patients are reporting diarrhea up to 5 to 6 times per day. Abdominal pain, if they have fistulas, a fever is common. Abscesses and severe inflammation. Abdominal pain is usually constant and located in the right lower quadrant. We were talking a little bit about labs before, so to continue on labs, we might see a decreased hemoglobin and hematocrit, low folic acid and vitamin B12, which can also contribute to anemia, decreased electrolytes like potassium and magnesium. As far as diagnostics, we'll probably see X-ray and CT used for imaging. Our interventions for Crohn's disease patients are going to be a lot of education, nutrition guidance, skin care if they have a fistula or an ostomy, and food avoidance. This is that cobblestoning appearance of the intestine with Crohn's disease. And here is a figure depicting fistulas. So on the left we have a fistula from the intestine to the skin, so it's almost like the body has created its own ostomy. And on the right we have intestine to intestine fistula.